in this town that we're in, if it's after 50 hours of care during Monday to Friday that exists for 911 to be available for the fire department, local volunteer fire department to be available, there's no ambulance. So they called 911 and they said, sorry, we don't have an ambulance for you. Just imagine what that must feel like. It's going to be an indefinite amount of wait because the one ambulance that serves an enormous area is in Louisville now because they were transporting the person, right? So we don't know when it's going to come.
Welcome to How I Doctor, where we're bringing joy back to medicine. Today, I'm joined by Dr. Tim Peck, Harvard-trained emergency physician, healthcare entrepreneur, and two-time congressional candidate who believes the only way to fix healthcare is to fix the government that controls it. He's also an ER doc who slept in a nursing home for 3 months to try to understand what elderly care is like from the inside. He was chief resident at Harvard's Beth Israel Deaconess Medical Center during the 2013 Boston Marathon bombing, where his team treated 23 victims and saved every life. Now he is running for Indiana's 9th congressional district as a Democrat in a deeply Republican district because he thinks, and I agree, ER docs have exactly the skills Congress needs: the ability to solve complex problems under pressure, make decisions with incomplete information, and stay calm when everyone else is losing their minds. I have previously talked with other doctors turned politicians. Tim's path, I think, is different. He's a centrist Democrat in a red county trying to prove that bipartisan problem solving still works and willing to lose over and over to make that case. I'm particularly excited to talk with Tim because he and I obviously share the same clinical training as emergency physicians, and I want to test this thesis that our specialty uniquely makes people prepared for political leadership and everything else. Dr. Tim Peck, welcome to How I Doctor. Before we jump into the episode, I want to thank our newest How I Doctor sponsor, Savaro. Savaro is a top telestroke and neurology company that was built to fix one of the most predictable failures in modern medicine: getting timely, consistent access to a neurologist when you actually need one. Their team of board-certified neurologists deliver rapid video response, clear decision-making support, and continuity from the first exam all the way through treatment planning and management. Hospitals working with Savaro see faster door-to-needle times, fewer transfers, and measurable improvements in patient outcomes. And because Savaro was built by physicians, the workflows actually match real-world medicine. If you need stronger, faster, and more predictable neurology coverage, visit Savaro.com to learn more. And now, let's get into today's episode.
Thank you, Graham. I appreciate it. It's an honor.
Tim, you've done emergency medicine, founded healthcare tech companies, and then, at what point did you say, oh yeah, let's run for Congress in rural Indiana?
I said, let's run for Congress a lot earlier than I actually put my toe in the water and decided to actually make it happen. As you said, I was doing residency at Beth Israel Deaconess, the Harvard program there, and stayed on as faculty for a bit. And then I left in 2013 to create my first startup. And that startup was called Call9 and created telemedicine technology. At the time, there wasn't much out there. And so we had to create our own technology. And as you said, I lived in a nursing home for 3 months to understand everything I could about that world, because you as an emergency doctor know that one of our favorite things to do is point fingers at the nursing home world and say, what are they doing sending these patients to us? So I wanted to go figure out why and then how we can bring medicine to people rather than people to medicine.
We're recording this the day after the first episode of season 2 of The Peck came out. I watched it last night. And I mean, the nursing home thing was even a trope on the show. The intern is teaching the med students, oh yeah, hey, it's 7 a.m. or it's 7:30 or whatever. It's when the nursing homes do their bed rounds and they find somebody altered and call 911. So it happens every day. It was a common trope that even Hollywood is using now. The thing I try to do, and I think I'm hopefully successful most of the time, is just the idea of get curious, not furious. Your nursing home example is probably a really good demonstration of that. It's oh, okay, I actually want to learn what is actually happening. It's very easy for me to make assumptions about why nursing home patients come in at 6 a.m. or 7 a.m. or whatever, but it's way harder to actually go do the hard work of oh, well, let me try to understand, not just jump to conclusions about how, bad this nursing home is or how lazy some person is that decided to do it this way. I think that's also a little bit of like an ER doctor ethos of like, I think we generally try to not ask things of our team members that we wouldn't do ourselves. I try to really have like a very low hierarchy world where a nurse feels comfortable to ask me anything because he or she knows that like I'm willing to get down and dirty and do it too. Tell me maybe a little bit more about the your nursing home story and what led you to do that.
I was looking for a way to be with people at the moment of their emergency. Right? We see these patients so much after the moment of emergency. When you really look into it nationwide, it's over 60 minutes before they see you, even in places that have quick response times. Because when you're thinking from the patient experience, it's when they pick up the phone to call 911 or someone else does, plus the wait, plus the time on site, plus the wait to get to you, plus the time that it takes for them to even see you because you have to get in there if it's not a, immediate trauma or a STEMI being called in kind of thing. And so it's a lot of time. And I think time is a concept that, having been a patient before with pretty critical illness, versus a doctor, it's warped, right? The Every second feels like a year as a patient. And while you're out there seeing 12 other patients and come back and feel like, oh, no time really has passed for me, as a physician, that person's just been waiting on care, just been waiting, right? And so I got kind of obsessed around how can we shorten that time. And again, telemedicine wasn't a thing. FaceTime was. And said, "Oh, what if we use telemedicine?" And one of the stats I like is that at the time, less than 1% of doctors knew what the term telemedicine was when there was a survey. Um, and so, yeah, using that to get to people. Then looked at where do people have their emergencies? And the one place where people really have emergencies and use the 911 system in a single building is a nursing home and rehab. Right? And so in my ED, 19% of the ambulances that came to the hospital originated from nursing homes. And so, got down to that. I really don't know what's happening there. I get bad documentation from them. I get patients that you're like, I don't even know why they're here. I get other patients that are so super sick, and you're like, How did they get to this point?" And instead of complaining about it, I said, okay, maybe this is the place, both operationally, where everybody is using it, I can get to, also just the highest need. And so I went and I emailed thousands of nursing homes, and a few of them got back to me and saying this crazy idea: "Can I sleep over in your nursing home?" And one on in Long Island, New York, said yes, and I found myself living there.
People say never waste demand. Like if there's a big demand for services, clearly nursing homes have a big demand for emergency care. Like that, go to where the money is. That's a great place to provide a ton of value and learn a ton about what happens. Maybe see patterns that maybe even the nursing home can't see. That you're able to see it with a fresh pair of eyes as well.
Definitely that the nursing home can't see, and definitely that emergency doctors can't see by being there and learning.
Yep.
Right. So it's that cross pollination, and it's go where the money is, go where the problem is. And that's where I saw the problem be largest. And then it is the money, right? We spend a ton of money on unnecessary hospitalizations. CMS says 45% of hospitalizations that come from a nursing home are avoidable. And it was true. When you got to patients early, our very first patient, Mr. D, I'll remember him forever. He was an old, gruff guy who his complaint was vague abdominal discomfort and constipation. And he was diabetic, and vague abdominal discomfort, right? The story is he was having an MI, and they don't have EKGs at a nursing home necessarily being done because there's no doctor there. It's a nursing home, not a doctor home. So with telemedicine, we could do the EKG right there by the bedside. I could see it. We have streaming telemetry. I could see that his O2 was low and put him on O2, get the IV started, call 911, give him his aspirin and have the IV ready for heparin. And so He left the hospital a few days later with a few less percent of his ejection fraction, and his life saved. And so that was great. But we also prevented so many hospitalizations that over the course of a couple of years saved Medicare $100 million in unnecessary hospitalizations, over 5,000 beds that we were covering at all times.
Is that kind of one of the big takeaways you learned was like the information was available, the patient was already symptomatic or whatever it is, and had you just been able to intervene earlier, you actually were able to dramatically change the course of this probably chronically ill, often quite frail patient's trajectory.
Absolutely. It's about getting to, and we would call it magic medicines, especially like Lasix would work better, right? Because you'd be there, just be like, why is this Lasix working so well? You're so used to giving it, and it's only going to work for output when they get upstairs, right? It's because
Yeah.
you're there so early in the evolution of these problems that these medicines actually have better effect because the physiology hasn't gone haywire yet.
Tim, it's a very morbid population. Probably it sounds like probably also a really high yield group where you can have a massive impact because the patient population is already so sick. You can, your number needed to treat is very small for giving Lasix to people early in their congestive heart failure fluid overload.
hmm Yeah, I think it's a sick population. It's a costly population, right? Most of these patients are dual eligibles, meaning they are eligible for most Medicare and Medicaid. And so it costs the system a lot to take care of these patients. And if you're doing it in a higher level of care that they don't, site level of care that they don't necessarily need, now you're even just exorbitantly wasting money. So we were able to get into risk-based contracts before they had started. Risk-based contracts were a real thing with providers, but we had to write new contracts from scratch. Like, this didn't exist. Like, now you can take a contract as a provider off the shelf and use it with a payer. But we had 13 different contracts with the insurance companies, et cetera, who loved what we were doing because we were saving money and improving care. And that included Medicare, right? Medicare had no way of paying us, no way of paying us at first. Telemedicine was essentially illegal, literally, to bill for. And we'd just be honest. It'd be like, we're using telemedicine to do critical care on a patient in a nursing home. And it would be like the algorithms of their computers would say, does not compute. You must have done something wrong. And again, that led me to Congress. So telemedicine needed to become a reality. And I worked with a bipartisan group of representatives to do so.
I want to take a moment to thank our sponsor, Savaro. If you've ever waited and waited for a neurologist to call you back, you know the problem that Savaro was built to fix. Savaro is a physician-led telestroke and neurology company that delivers rapid virtual neurology coverage that's reliable. Their board-certified neurologists connect by video in under 45 seconds, and they stay with you through the entire decision-making journey. Hospitals working with Savaro report faster door-to-needle times, fewer unnecessary transfers, and measurable improvements in patient outcomes. If your hospital needs stronger, faster, more consistent neurology coverage, visit Savaro.com to learn more. Let's say you win in Indiana and everybody in Congress agrees with your solution to improve skilled nursing facility care. What's the bill look like?
Yeah, certainly. And there's a number of different bills to talk about here and ways to improve healthcare. We're talking about one slice of it right now in terms of bringing technology into nursing homes. There's something called the RUSH Act that we wrote, reducing unnecessary senior hospitalizations, that got introduced to Congress. And then kind of pieces of it got absorbed into other bills as the pandemic came and things needed to change. So what that does is allows provider groups to work with nursing homes and Medicare to share in savings together. So by enabling this, you change the payment model to not be based on fee for service and instead have real, essentially risk-based contracts with Medicare directly, not going through the insurance company Medicare Advantage, but having Medicare do it itself. And so this was, moving forward, introduced, had representatives, had senators going forward, and then it actually kind of took a big back seat when the government shut down for the first time in 2019, for the longest time in 2019. And then when it came back up, it was the pandemic, and rules of all sorts got changed.
It feels like we're in a super weird time where there's a lot of awareness about how expensive healthcare is. How do you understand the moment we're in healthcare as a doctor, as a candidate for Congress, where we both like want to have prevention and want to save money, but then have these other parts that seem totally antithetical to preventing disease? And I would argue, as a fellow doctor, like if you're kind of anti-vaccine, you're kind of pro-disease in some ways as well. Like, does any of this, this
Yeah,
make any sense to you?
it actually does make sense to me in ways, and let me explain
Please
how I
explain it.
think about
Please make the
it.
world make sense to me, Tim. Please.
I think we're in, and it's hard to see it when you're in it, but I think we're in a predictable moment in time because of the way our healthcare system was designed. It was designed poorly to be around fee for service. And in the 60s, when we introduced and had the bipartisan amazingness to put together Medicare and Medicaid and the VA and all these programs, unfortunately, we based it all around fee for service schedule. And so from there, you had eventually this arms race between providers and payers where you just have all this muck and middleman in between, PBMs and EMRs being used for, revenue cycle management and versus, prior authorization. And then let's put AI into this. And how do we fight even more? Right. So that all roots from 1964, right? Like that's when this really got started. And so
Yeah.
we set off this course that if you were sitting in the mid 60s looking at this and we're like, okay, let me think through, let me gamesmanship how this would work and how this would look, you would eventually get to this arms race where you're here today, where the system's going to have to break. It's going to have to tip. It's going to have to change. And so when you have chaos, you're going to have chaotic solutions, right? And people will need to be grounded in something. And I think what RFK, who I disagree vehemently on so many things, but also had a message of giving people a grounding for some people, right? To say, okay, here's something you can do. Let's look at vaccines. Let's look at diet. Let's look at these things in a different way. Is it the right solution? Absolutely not. It's not the right solution, but it's predictable that someone with power with a name will come along and try to give a certain solution. We as doctors and as a scientific community need to come together to give our own solutions that aren't tied to the past, that acknowledge how bad this system is and say, I don't want to improve and incrementally improve what we already have. Let's just change it. Let's throw it out and try something new. And this is what it might look like. And I think the biggest part is the fee for service part. I think it is infused into everything we do as doctors. And we know nothing to do with what's right by the patient. We got to get ourselves out of that and fight against it.
I love that. Yeah, I do think we need to reimagine what we really want and need from a healthcare system and sell that vision to the public, to to patients. I think as Ezra Klein on the New York Times, the headline was like, "Maha is the wrong answer to the right question." And I thought that was a really good way of framing it. That like the one of the only things I agree with RFK Jr. about is like, yeah, we have to come up with a new way to keep people healthy. I don't think it's wrong to have questions around the health of our country at all.
Right. That's right. And if you start, and what we're doing right now is what I try to do with every voter in my red district that I get to speak to is get down to where we can agree. Pretty sure everyone can agree that the right question is, why is this system not working for most of us? And then now let's talk about solutions, right?
Tim, I wonder, are there groups that typically agree with your perspectives? And then I wonder, just talking about politics, like how does that align or complicate things when we talk about who's going to fund a campaign and support you if you're, you know, biting the hand that feeds you, as well?
Yeah. So the groups are the people you're actually supposed to be representing. And they're often, even if they're educated individuals and very, smart when it comes to politics or other things in the economy, these points that we're talking about and how the healthcare system works is is obscured to them in many ways. How do you simplify this messaging to say, what's happening right now is wrong? And as you said, as your client said, the question's the right question, but the solutions are wrong, right? And say, hey, I need you all as individuals to help make the grassroots movement to make this happen. My donors uh, versus my competitor, I have thousands more donors, right? But they're individuals who I have to talk to get that support. And that's growing and growing and growing. I have 900 volunteers. I'm pretty sure my opponent doesn't have any, right? She doesn't care to, because they've had the control for so long. And so this movement has been building. And like you said, you got to be willing to lose for a bit. This movement has been building to a moment where there is enough name recognition, is what they call it in politics, but really it's enough trust with individuals to say, I'm going to keep showing up, I'm going to keep trying to make this happen. And hopefully enough of people will vote for me this time to show what I can do when I'm there.
Let me ask you about what maybe being a doctor or being an emergency doctor brings to the campaign trail. I think one of the challenges that I love and is also can be difficult at times is like building rapport. I wonder how much of emergency medicine and those skills, those kind of social skills you can use on the campaign trail when you're meeting somebody that maybe doesn't agree with you or doesn't vote Democrat.
There's this study that I have held with me since I learned about it in medical school, which is they had a number of doctors go into a room uh, with a pager on their side, and then were paged at 5 minutes or 3 minutes into it. And then half of the doctors sat down and spoke to the patients, and the others stood up and spoke to the patients. And then they went in and said, how long do you think your doctor was here? And on average, the people who had the sitters thought it was longer. Um, so, how do you slow things down in order to speed up, right? Go slow to go fast. And I think emergency medicine is all about that. And we are taught in critical care moments, how do you slow things down through algorithmic problems and checklists and things, but also just like orchestrating all of this going on when everyone's running around and you having a slow heart rate doing that. But also, how do you slow down with people in that first moment that you're talking about when you walk in and have to feel someone out? I just sit down. I cross my legs. Like the nurses know to bring a stool into a room if I'm working,
Yeah.
right?
Yeah.
To be able to do that, and I kind of bring that same ethos to politics, where you see someone, just look them in the eye, take a deep breath, slow down, shake their hand, and listen to them before you interrupt them. And let's let that person talk before you give your own solutions and your own answers. And so, um, in terms of translating emergency medicine to everyday life and politics, that's one of the things that has brought a lot of effectiveness, but also getting back to it, a lot of joy. It makes the job better to sit down and cross your legs. It just makes the job better. And in the end, you can get a lot more done.
Tim, I'm from Kansas, healthcare deserts in most of that state. You talk about healthcare deserts in southeastern Indiana as well. Maybe just describe what that means to you. What does that mean in terms of access to care and specialists and testing? I live in San Francisco now, not a healthcare desert. a very different experience, I'm sure, than your practice of emergency medicine than mine.
Yeah, and I did train in Boston and New York, so, have the definitely the yin and yang of it. So, um, I'm on this, committee called the New Washington Beautification Committee. So I live in an unincorporated town of 500 people, and it's an unincorporated town. So you need these committees to do things, and we do basically pick up the garbage, as well as help with the light up of the Christmas tree and the trunk or treat. So I was at the trunk or treat just a couple months ago, and there was a little boy who fell off his dad's shoulders, a year or two old, and wasn't moving at first, and lost consciousness, wasn't crying, uh, P-Carn, we got to do something. So um,
Yeah, yeah.
we called 911. It's about 6 o'clock. And in this town that we're in, if it's after 50 hours of care during Monday to Friday that exists for 911 to be available for the fire department, local volunteer fire department to be available, there's no ambulance. So they called 911 and they said, "Sorry, we don't have an ambulance for you." Right? Just imagine what that must feel like in that
Yeah.
moment. You're the
Not
mom.
like it's gonna be a long wait, but there literally is no ambulance?
It's going to be an indefinite amount of wait because the one ambulance that serves an enormous area is in Louisville now because they were transporting the person. Right? So an indefinite. We don't know when it's
Yeah,
and it's not going to be anytime
yeah.
soon. Um, and basically they ran and got me because I was there, and went over and I said, "You get in the car and go." Like that's all I say. My across the street, the farm across the street, um, the wife had lost pulses, and the husband was doing CPR for 45 minutes before the police showed up, and another 15 before ambulance finally showed up, and had to transport her, 45 minutes with lights and sirens on to the nearest hospital. So, and that's because they had to pass the closed hospital to get there. Right? It's not, "Oh, you live in some rural area, so you're far away. Don't you?" And that's another thing. People are like, "You deserve to not have healthcare because you live out there," right? And you're like, "No, we need a healthcare system that treats all Americans." And the big thing that people don't know about in cities, I think, is we hear that 8-9% of people are uninsured in America. Uh, White collar workers, it's about 1, 2, 3%. Truck drivers, farmers, agriculture workers, forestry workers, it's 28, 29, 30%, right? So how do you keep a hospital open? And in our case, Charlestown, Indiana, right next door, when 30% of the people walking through that door can't pay for their care, or at least can't pay for it today and need to go on a payment mechanism for the next 10 years. And so you just can't. And so we talk about this need to insure people and make sure that they're insured. And I think it's so important. And whether you want that to be Medicare for all or you want that to be some other program, I think again is the same questions that you were saying before. What's the solution might be different, but the problem we've all identified as the same, which is we can't keep our healthcare businesses open if people can't pay for the care. And so we need to insure people, everybody. I personally don't think that's through Medicare for all. I think there's a different way to expand that. But we need to insure everybody universally and then also bring prices down on the other side by taking out some of the middlemen, by eradicating fee for service dominance, and at this and make it so that the costs and the coverage start to even out.
I always struggle with this idea, Tim, where we've kind of decided that healthcare in the United States is a profit making entity. It's not really as much. I think in other countries it's viewed more as a service than a way to make money. And I struggle a little bit that it's like healthcare is a business, but it's also like a hospital. It's also a public good. It's in some ways it's like a library or it's like a road. If the hospital, your hospital that went out of business in your area couldn't make ends meet from financial decisions, but then there are consequences to everybody at the same time. Like, how do you, as a tech guy and an entrepreneur and an ER doctor, how do you carry those two visions of healthcare in your head?
Whole communities suffer when a hospital goes down.
Yes,
And even
yes.
when the hospital is suffering, it's not just the healthcare, but the jobs, the property values, the everything gets crushed. Um, the services that a hospital does to outreach to, the help for people who are indigent when they need it, everything that we think of that happens in a hospital. I'll give you two more examples of hospitals in my district. One is a critical access hospital in a town called North Vernon. That wasn't always critical access and has become more and more. And they no longer have security. So they the local police, call 911 and the police to come and handle behavioral emergencies. Nevertheless, people walking into the ED with a gun. So, you know, uh, that is just an example of what it starts to look like before it closes. It just drains now your police force going to this hospital rather than other. It just has so much of a web. There's another one called Harrison Hospital in our area that just closed their program, and they're underwater, and it's not getting better. I think this is America built off of capitalist program to get us where we are. Um, and I fully believe that if you have a taxpayer dollar that's coming out of your pocket, like you look at your paycheck and you pay Medicare taxes, that tax money should go to provider care, period. If it's going to if it's going to pay for billion-dollar ad campaigns or executive bonuses or shareholder profit, or if it's going to prior authorization programs, no, it cannot and should be audited and followed so that it goes directly to patient care, period. Everything else you can make profit off of. Now you've built a foundation of a business, right? You know, build a business off of that. And that's, thank you, government, for giving me the infrastructure to build a business off of that, right? It's not like you're taking away the money out of these businesses. You're propping it up so that it can build something else. And so do that for however you want to charge customers for whatever you're doing and the innovations that you're doing. Raise money from venture capital, raise money from the community. I don't care. We'll support you, but do not use my tax money to make it so that prior authorization stands in the way of me, their provider, and you, the patient.
From your campaign experience, what's the biggest healthcare access issue that voters talk about that maybe physicians wouldn't necessarily think about or consider as much as we should?
One of is my son, my daughter, my nephew, my wife died of opioid overdoses. That is a real fear. And again, we have an administration right now that's feeding off of that fear. And so it is deep and it's real. Of, oh man, I watched my high school football star become a drug addict and die, right? And they looked like a different person by the time they died. Like, it just kills communities, kills families, and it's often done very quietly. And one of the great things about medicine, as you know, is that people are vulnerable to you and tell you the secrets of their life, their health life, that they don't even tell their own husbands and wives.
Wouldn't tell anybody. Yeah.
Yeah, exactly. When you're looking to represent them in politics, they do the same thing, just about their more personal lives and their economic lives. And they will tell you about that mortgage that they can't pay anymore, that they didn't tell anybody. They might not even told their spouse yet. They were the one who controls the checks. And when it comes to that crossover between health and that privacy of family life, opioids are the thing that is so detrimental. And similar to nursing homes, kind of bringing it all 360. When you're in the ED and you get these patients from nursing homes and, they can't speak to you and they have quiet delirium and they're just internally preoccupied and they're sick and you're like, this person is a shell. 3 hours before I got to see them, they weren't a
Yeah.
shell, right? They were an interactive member, And so you see what's in front of you. And I think we do the same for patients who come to us who are on opioids, who are struggling with them. 5 years ago, they were in college, they were holding a job, they were a loving family, they were a member of society, and now they're not. And you just have to remember where they were, and people are people on a different moments of their journey, and you're seeing them at the worst, and remember that they have a better life before, and they can have a better life moving forward too.
I think that's one of the things I've been most appreciative of as an attending that I wasn't as a resident. That, as I've seen some of my patients, often with alcohol use disorder or meth use or opioid use, you see some of those patients come out the other side, and you'll see them for something unrelated 3 years later. They've sprained their ankle, and you see the name come up, and you said, "Oh my God, there's no way that's Steve or Joe or Susan, whoever it is." Like, oh my God, you're a different person. You look, you're absolutely right, Tim. We see them at their worst. We are unable to access that part of who that person is. And then hopefully, if they get the treatment and the support they need, they return to this person that is three-dimensional and is not just a diagnosis or not just, a frequent flyer or something like that as well.
I think weight is an even more taboo version of that, where people gain tens, hundreds of pounds in moments of stress and anxiety and depression in their life. And we see them, and you pass immediate judgment. Uh, you know, Ozempic and tirzepatide and all these medicines are going to really be a challenge. I think we'll have more of those experiences that you were just talking about in terms of drug and alcohol addiction, where you're going to see someone 2 or 3 years later and they're there for their sprained ankle rather than their MI. And you're saying, well, what happened?
Yeah. Yeah.
Your life
Yeah.
has changed. And so I think I'm excited about the breaking of taboo, even though we'll have to go through a taboo moment to get there.
Tim, where can people find you, learn more about you, and support you on the campaign trail?
You can find our campaign and my campaign on timpeckforcongress.com, forcongress.com. You can contact the campaign there. You can also contact me. One thing that the great Lee Hamilton, who was a representative, a Democratic representative from my area for 31 years, who was known for working across the aisle, did, and he told me, was give out your phone number. I said, okay, it's a modern world. Are you sure we
Wow.
should do that? And he said, give out your phone number. And I do give it out for people to contact me. And you have some contacts that are a little bit out there, but every once in a while you
Sure.
get
Yeah.
that will engage. So 812-287-9079. You can get in touch with me.
Amazing. That's our first phone number on the podcast for sure.
There it is. Yeah. Also working on something called Project Next, which we didn't talk about, which is a podcast that's for local issues and trying to tie local things happening to national policy of this Kentuckiana area. It's called, Louisville metro area. So projectnextindiana.com. And please reach out, and would love your donations to make this happen. As we said, I can't rely on PACs, and I can't rely on larger organizations as I go after the system itself and say it's not really working the way it is. And so individuals and especially physicians are how we've been able to fund this movement.
Dr. Tim Peck, it has been such a pleasure to get to talk to you. I just love your ability to combine the heart of emergency medicine and being a physician with representing your district and your community in such a great way. It's been wonderful to get to talk to you, and best of luck on the campaign trail.
Appreciate that, Graham. Thank you so much for having me.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.